Hello and welcome to the JCO Precision Oncology Article Insights. I'm your host, Dr. Carolyn Lineen from St. James Hospital, and today we'll be discussing the JCO PO article titled Prognostic Significance of Blood-Based Multicancer Detection in Circulating Tumor DNA 5-Year Outcomes Analysis by Dr. bySwanton and colleagues. Blood-based multi-cancer early detection (MCED) assays represent a significant development in oncology, offering the potential to identify multiple malignancies through a single, minimally invasive test. These assays rely on the detection of circulating tumor DNA, fragments of genetic material released into the bloodstream by cancer cells, and the identification of tumor-specific genomic and epigenomic signatures. The study examined in this episode evaluates the prognostic significance of such an assay using data derived from the circulating cell-free genome atlas. The analysis focuses not merely on the ability of the test to detect cancer, but on whether the cancers identified correspond to clinically meaningful disease and whether survival outcomes align with established expectations. The study cohort comprised 2,513 individuals with confirmed cancer diagnoses across a range of tumor types and stages. Participants were stratified into two groups, those in whom a cancer signal was detected by the assay and those in whom no signal was identified. This distinction is central to understanding the biological sensitivity of the test. Survival outcomes were assessed over a 5-year period and compared with expected survival based on population-level data, adjusted for cancer type, stage, age, and other prognostic variables. A key finding of the analysis is the association between cancer signal detection and mortality. Among individuals who died during the follow-up period, 85% had a detectable cancer signal. In contrast, only 34% of those who remained alive were classified as signal positive. This marked difference suggests that the assay preferentially detects cancers with higher biological activity, greater tumor burden, or more advanced disease states. From a clinical perspective, this indicates that the test is not random in its detection patterns. Instead, it demonstrates sensitivity to features associated with disease severity. Importantly, the relationship between the detection status and survival outcomes demonstrates close concordance with expected prognostic trajectories. In the signal detected group, observed 5-year survival was 43%, compared with an expected survival of 40%. In the signal not detected group, observed signal was 88%, exceeding an expected survival of 81%. These findings indicate that the assay does not preferentially identify cancers with atypical or disproportionately poor prognoses, nor does it selectively detect unusually indolent disease. Rather, the distribution of outcomes among detected cases appears consistent with established patterns of disease progression and survival observed in clinical oncology. This observation is particularly relevant in the context of overdiagnosis, a recognized limitation of cancer screening programs. Overdiagnosis refers to detection of malignancies that would not have become clinically significant during a patient's lifetime. Such detection can lead to unnecessary diagnostic interventions, overtreatment, and associated physical and psychological harms without conferring a survival benefit. This study provides evidence that the blood-based multi-cancer detection (MCED) assay does not substantially skew towards the identification of indolent or clinically insignificant disease, nor does it disproportionately capture highly aggressive cancers in a way that would distort overall prognostic interpretation. Instead, the assay appears to reflect the underlying biological heterogeneity of cancer as encountered in routine clinical practice. Despite these findings, important limitations must be acknowledged. The study is observational and prognostic in design. While it demonstrates that detected cancers exhibit survival patterns consistent with expectations, it does not establish clinical benefit. Specifically, it does not demonstrate that the use of the assay in asymptomatic populations leads to improved treatment outcomes or reduced cancer-specific mortality. Establishing such benefit requires large-scale randomized controlled trials in which individuals are assigned to screening or standard of care and followed longitudinally for clinically meaningful endpoints. Additional considerations remain relevant to the potential implementation of multi-cancer early detection testing. These include the identification of appropriate target populations such as age-defined or risk-stratified groups, the determination of optimal screening intervals, and the development of standardized diagnostic pathways following a positive test result. A positive MCED result presents unique clinical challenges, particularly when the anatomical origin of the cancer is not immediately apparent. This necessitates coordinated diagnostic workflows, including imaging, lab testing, and potentially invasive procedures. The cost effectiveness of widespread MCED screening will depend on factors including test performance, healthcare system capacity, downstream diagnostic costs, and the magnitude of any survival benefit achieved. In a broader context, this study contributes to an evolving paradigm shift in cancer screening. Traditional approaches have been organ-specific, targeting individual cancers through dedicated screening programs. In contrast, MCED assays propose a systemic approach, leveraging circulating biomarkers to detect malignancy across multiple organ systems simultaneously. Such a shift has the potential to expand the scope of early detection, particularly for cancers that currently lack effective screening strategies, such as pancreatic, ovarian, and certain gastrointestinal malignancies. In summary, this study provides important evidence regarding the prognostic validity of blood-based multi-cancer detection. It demonstrates that cancer identified via circulating tumor DNA exhibits survival outcomes consistent with established expectations, thereby addressing a key concern regarding potential bias in detection. While these findings support the biological credibility of the assay, they do not yet justify routine clinical implementation. Further research, particularly randomized control trials, is required to determine whether MCED testing can meaningfully reduce cancer-related mortality and improve patient outcomes at the population level. Thank you for tuning in to JCO Precision Oncology Article Insights. Don't forget to subscribe and join us next time as we explore more groundbreaking research shaping the future of oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.